for joining us today. I would like to welcome our first speaker, Dr. Samya Nasr. Dr. Samya was from the perspective of cystic fibrosis. She has a vast experience, and I really appreciate her efforts to push the CF care for our patients forward. And I'm very interested to hear her next talk, the protocol for CF treatment in Egypt, modified from the US recommendations, understanding that there is a really, really big difference between the environment for patient care here and there. So, Dr. Samya, I'm very excited to hear this talk. Thank you.
Thank you. Right, again, it's my pleasure to be here. This is my home. I love it here, but then I say the same thing in Aisha, so I'm not lying. Your both places are my home. So I wanted to talk about this because, I created this treatment protocol several years ago when I was here for sabbatical in 2022. And since then, I presented it, and some people are not still following it, so I wanted to make sure I'm going to be presenting it over and over everywhere, because it's very important to start using the same protocol for in all centers. So that way, at least we have unified protocol like we do in the US. In the US, we have a protocol, we deviate from it a little bit, but at the end of the day, most of the centers are following the same protocol. So that's really very important. Well, the next step is to do a registry, but that's a bigger project, so we'll talk about that. By the way, I talked to the Ministry of Health about having a registry through the Ministry of Health or for all the colleges that have CF patients, and that there's some possibilities, but not right away, I guess. So that's bottom line, but we'll work on it. So, this is just a summary. I know you know all of that, but just to remind you about what's happened since 2021, since I started. I've been working in CF in Egypt since 2000 with Maggie and Dr. Samia and Hamha and others here. And then, so it's been a long process going on. So, but since 2021, we were able, after lobbying the Middle East CF Association, which is funded by the CF Foundation in the US. I've been talking about that the CF Foundation changed direction. Before, they would only fund things in the US, but recently they had extra money and they were able to, support things outside. And also realize that a lot of people outside, a lot of CF patients outside the country are really, especially in low middle income countries, are really suffering and dying young. So in 2021, we were able to get 4 equipments. There were supposed to be 5 because Alexandria was going to get 1 as well, but they never really finished the paperwork, so we didn't get it. And you guys had your equipment from that Dr. Mona brought in earlier. So we send it to Ain Shams, Aziz, Asyut, and Sohag, and the idea is to make it spread out over Egypt, so that way patients don't suffer too much by traveling. But again, they have to travel to these 4 universities or go to Alexandria and Cairo. Alexandria, they said we have a lab that we send the patient to, we're fine, so fine, and we're not gonna need to have them. So that was the beginning of like the next phase in my work here, because before that, it was mainly coming in every year, talking about CF, trying to get people excited about it, especially through Dr. Nader's conference. But then in 2021, when I got the equipment here, we started working more together. We started having collaboration. I have several WhatsApp groups that we communicate through with everyone. And when I said I really want a Zoom meeting, we usually try to do it real quick, and they all try to join. It's usually at 11 o'clock your time, so after the clinics. So, the goal was really of the collaboration since 2021 is increase awareness of the physician and staff about CF, develop CF guidelines, because very important to have guidelines, so we're following it so we can compare results. So if you're following the same guidelines, then you can compare results between universities. Develop multidisciplinary team, and I think I mentioned earlier, Ain Shams actually didn't know what multidisciplinary team is, but when we presented it, they actually surprised me last April when I was here. They said, oh, by the way, we did it. And I really didn't, every time I come, there is a nice surprise, so that was a very nice surprise for me. And actually, we did questionnaires for families before and after the multidisciplinary clinic to see the perception of patients and also the perception of physicians. And I submitted an abstract to the North American CF meeting about that, because that's really nice progression. So I didn't include you guys because we weren't working together at the time, so next time you will be included. So training faculty, staff, and families as well, because that's very important. By our team, and my team has been very happy to come in, and as we saw, Laura was very excited to come in as well as a mother. I asked the 4 universities, what exactly do you want me to focus on? And the message I got was nutrition and physical therapy. Main thing that they were really focusing on. So I've been bringing my dietitians, the CF center dietitian and physical therapist. I think that's going to be their 3rd or 4th time coming in, maybe 3rd. And that's been very helpful to them. And that's how we got the GI and the nutrition department to come in to work with us by seeing what we do in the US and then just try to multiply to do it here. And the rehab people are really been very, very excited to join us. The microbiology lab here, I think they're okay, but I'm not sure. I don't know if they're able. I mean, you have to send it to a private lab, right? Not university lab for the sputum samples to be processed.
No.
Here, oh, okay. I think some places they just have to send it outside. I mean, I remember the first bronch I did here with Dr. Samya. The dad took the sample, the bowel sample, and walked with it. And I was like, where's the sample? And Dr. Samya said, oh, he's taking it to a private lab to test. So that's all the stuff in my head. All right, this is the start of, during COVID, we had a meeting in Alexandria to talk about how we're going to do the teaching for, they have this web testing equipment, how we're going to do the teaching about it. And then, as you see, people from Ain Shams, from Asyut, so had somebody that joined us at the time. But yeah, so and Zazi was there as well. So I started more also in the fall. So I came back in the fall. So that was in May when we started talking about the equipment, and then the Zazi actually were very good in, they were able to get the training virtually from the company that have the sweat test. And they taught the others. So they were able to have a workshop in Dr. Nader's meeting, and they taught the other people, other centers. So that was really good in May. And then in the fall, I came back, and the CF Foundation has been very supportive in all of that. They've been funding me, so which is really great. And I did like what I do in the US. I do site visits. So I go from center to center to see how they are following the guidelines, is there any potential. For here, I did it to see if the administrators will be able to get special coffee for Dr. Naveen, just came in. So I just went to each university. So what capabilities they have, the 4 universities. What capability they have, and also are the administrators, the dean and the head of the hospital willing to work with them. And it was very nice interaction, and everybody was very supportive. In the summer of 2022, I had sabbatical, which in the US, that means you can take 6 months, your salary is paid, and you do whatever project you want. And my project was here. So I actually came in, the university was supportive, and the foundation was supportive. So I came in the summer, fall kind of thing. I spent about 3.5 months working extensively with Ain Shams and with the others as well. And then I brought the dietitian and the physical therapist. One of the time I brought the psychologist last year. She came in. So this is, I mean, you guys love pictures. So all we have, I have tons of pictures. So that was the Z and French. So the specific objective of the project, and I have to be very specific and very systematic in my work here, because I'm reporting back to the foundation, but also I'm writing up. I love to publish. So I have to be very focused on what we're asking and what we're doing and collect data as we go. That way it will be publishable, if you will. So when they did the multidisciplinary team in Ain Shams, I can't just submit that. I wanted it to be evaluated. So that's why we did the questionnaires for the families and the physicians. The objective is to implement state-of-the-art world-class multidisciplinary team in Egypt. And yes, you can do that here. Train multidisciplinary expert in CF, and I think that's going to be a focus tomorrow, right? They're going to be, or next week when Chris and Stacy are here. And then to improve the clinical outcomes. And to improve the clinical outcomes, you have to follow the guidelines, but then you have to do the QI work. Because the QI work will measure your improvement. The Turkish group are doing awesome job, and that's actually hurting other centers. So in Jordan, they are not doing as well as Turkey. Well, so that's a problem. But you know, here, I'm hoping we'll be better. We're not going to be as much as Turkey, because Turkey, they just ran with it. But who knows, maybe we will. And then we really, at the end of the day, we want to have a network. In the US, we have a network of centers. So we all work together, we all communicate with each other. So it will be really nice if we have a network of physicians or if centers hear about CF care. So if there is a problem, if there is something. Right now we kind of have one because, and now you're included in it, where we communicate periodically, have the Zoom meetings and communicate periodic problems about successes, things like that. And that, at the end of the day, will reduce morbidity and mortality. And last year when I came, Dr. Iman mentioned that the median age of diagnosis used to be like 4 or 5 years of age, and now it's down to like 8 months. So that in itself is a huge progress. So we need to develop national standard of care, like I mentioned, and establish a national advisory board. We started that in Ain Shams. We have some families and I had several meetings with them. And they joined, some patients joined from the Azib. Will be great if we have from Cairo as well. Because if you're lobbying, you have to have patients with you, because that's the face of CF. And then advocate the university, the Ministry of Health, which successfully is started. So I'm really excited about that. What happened in November of, not last year, the year before, is that we sent several letters to the Ministry of Health. So the Minister of Health got a letter from me through, I had some lawyers that helped develop the letter. We had a letter from MICFA, from the Middle East CF Association, sent to him. And then we had Dr. Mona Benzouri. She's related to the Minister of Health. And I sat next to her and she was mentioning that, and I'm like, you call him now. And she did. So poor guy, got attacked from every side. So we ended up meeting with Dr. Hassani, and he's been wonderful to help us with. He delivered on what maybe half of what he's agreeing to, but it's okay because I keep repeating until he's going to do everything. And really, right now, I think here and in Ain Shams, you guys are ready for quality improvement. And that is very important to show the information before you have you got started the QI work, and then as you're doing it. Very, very important to focus, and that's a major focus in the US. This is Stacy in the right, and as you can see, because she's speaking in English and there was parents there, so she had somebody from GI to translate to them. And they actually took her recommendation of high-calorie supplements and they translated it into Arabic and added things in Arabic that we don't. She kept saying peanut butter, and they said peanut butter is very expensive. So they had alternative to it, so that's for it. And this is Chris trying to do airway clearances for little baby. So to focus on the outpatient care for CF, and again, that's taken from my protocol in the US. So we can modify it more, but that's what I have right now, and that's what we've been working on. So in the US, we see the patient's first year of life every month, and then after that, every 3 months. I know that we see patients here every month because that's how they get their medication. So even better. So that's wonderful. But then for patients 6 years and older, we do spirometry. So automatically. So they come into clinic, before I see them, they get their spirometry done. And as Sharon mentioned, if the spirometry is lower by 10% from within the year, then they give them bronchodilator and repeat the test to see what are they reactive, or are they having infection that we need to treat. And then the dietitian see the patients every visit. And I know you don't have a dietitian here, but your nutrition department can help with that, and the GI department. I don't know politically which one does it, but in IHM's nutrition does it, and GI does if there is any problem. And then patients should be seen by a physical therapist at least once a year. Chris does see them once a year and as needed, like more if we need to. And then we do the sputum or throat culture every 3 months. In here, you might want to do it every 6 months. It's okay. But it has to be a good lab that does it. And sputum is better than throat. And then we do the blood work, which include the CBC, include the chemistries, includes PT and PTT, and include the OGTT, the hemoglobin A1C. And the OGTT is once a year when they turn 10, or earlier if there is family history, or there is symptoms. Any questions?
I was wondering about the physical service. Do you see the patient once per year?
No, I mean, this is the minimal recommendation.
Yeah.
But for you, because you're starting with that, it's really good to do it more often, maybe every 3 months or every 6 months. And the idea is to teach the patients that really hand percussion is fine, that aerobica is fine, because they're all focused on the vest, but really can we focus on other things, can we focus on exercise? So he'll go over all of that when he comes in.
Because the idea is to train the patient they can use the therapy at home.
Yeah. So the vest that we brought with us to IHMs, they have it in the clinic. So the patient, when they come, they get a session. But really for home, you should be doing it by hand or aerobica. They know aerobica is
that the vest is better than hand percussion.
What that?
The idea of the patient is that the vest is better than hand percussion.
Mm-hmm. Yes.
Because actually it gives a same result. If the vest is effective as a hand percussion, hand percussion is effective.
So hand percussion is as effective as the vest.
Yeah.
The reason I use a lot of vests in the US because insurance covers it, and because it saves time, because you can do the vest while you're doing the nebulized, pulmodyne, albuterol, a hypertonic, all of these things. So we start, any CF patient comes in, and a lot of my patients, I see them at first because we have newborn screen, so they come in, they have no symptoms whatsoever yet. Some of them do, but a lot of them don't. So we start them with bronchodilator. So we start albuterol right away, and I can start with either nebulizer or inhaler. I started going to nebulizer. The reason for that is that when they start getting sick, I'm adding pulmozyme, or hypertonic, or Toby if they have pseudomonas, through the phone. So if they don't have the machine, then there is a possibility of delay. So I sometimes just do the nebulizer. But we usually give them either nebulizer or inhaler. The N-acetyl cysteine, since you don't have pulmozyme in the country, you can use N-acetyl cysteine 10% 3 ml nebulized, not oral. And I know it's available here, and actually it's not. Yeah, I know it is, yes. So that's really important too. So we start, and so the N-acetyl cysteine and the pulmozyme I add if they start getting sick. So I have a patient that was doing really well till 5 years of age, and all she had is albuterol and airway clearance. And then she started going to school and started having germs, and because mom was very hesitant, she didn't want anything added. So the plan is, okay, when she starts getting sick, I'm starting Pulmozyme, and then I'm starting hypertonic, and mom was okay with that. So we waited till 5 years, but generally within the first year we do it. Hypertonic, I know you have 3% here. 7% is what's studied, so if you have 7%, that would be better, but 3% is fine. You have that?
By some pharmacies.
Oh, okay. But I know that in the university, you can have them do it for you, right? The pharmacy. Yeah. So 3% or 7%.
Yeah, is it possible like to have a formula for the 3%, 7% that we can give the patients and they can prepare it in their local pharmacy? And you understand how many grams of this, how many milliliters of the water, and then the pharmacy can, and they can just give the formula to the pharmacy and they will prepare it.
That would be actually a QI question. Yeah. That's all you're gonna hear from me. Okay? QI.
Okay.
So yeah, so you can start by, you have a PDSA cycle, and that very limited, that you're doing it in the hospital. Can we do it locally so it's convenient? Then you work with your pharmacy here to get the formula together to make sure there's not going to be contamination, because I don't want to nebulize water, that's not good. And then measure it after they do. Is that better in the lung function, better in the adherence? And then that would be a QI fraction. So we'll work on that. So that's actually a good one. The percussion and cultural drainage following bronchodilator usually. And then the N-acetylcysteine, Pulmozyme or hypertonic usually. N-acetylcysteine here we do it twice a day, Pulmozyme is once a day. And then the hypertonic is twice a day. You can do N-acetylcysteine once a day too. But this is the order, and I'm going to go over the order in a minute. Pancreatic enzyme is very important, and like in Tunis, they don't have pancreatic enzyme, they have tracasta. They don't have pancreatic enzyme, which is very interesting. But here, I think the pancreatic enzyme sometimes there is a shortage. A lot of times it became more available since Dr. Iman joined the Ministry of Health dispensing. Because before they didn't understand what CF is. So you go, the parents will go to the Ministry of Health, and the physician is like, "This is too many pills. I'm not giving you that." Or what is CF? And then the parents are educating them. So it's better now through the communication with the Ministry of Health. The vitamins, I know, this is the story of my life. So the vitamins, supposedly you have it in Egypt. The company that have it in Egypt never registered, or they're still working on registering with the Shara al-Muwahhad. So they've been giving it to families for free, like to universities for free, which is kind of interesting. And I talked to him this time, and he said he's still working on it. Hopefully he'll be done with that. I connected him with MICFA, and they tried to have the product in Jordan, but Jordan has to have not the generic form. They have to have the CFs, American CFs, vitamins, which is going to cost them a lot of money. So instead, they actually are now going to like Pakistan and other countries that MICFA is using. So our vitamin company here should be up and running very soon. And we looked at the component, and Stacey said it's good. He wanted 5 drops once a day, and she said if you do 10, you should be good. So 10 drops. So hopefully it will continue, and I'll meet him again and ask him more questions. We do PT and PTT because a lot of times the vitamin K is deficient, and that's how we measure for vitamin K. If it's deficient, we give them the 5 milligram tablets. I don't know how it comes here. We give them half a tablet twice a week. And this is the order. We always get asked that by families, and also when you give talks. So it's very important to look at, why are we doing the order? So to educate the families, we wanted the airways to open, so you give the bronchodilation. Then you hydrate the airways by giving the hypertonic. Then, and also it's cough inducer. So you're making the patient cough, which is a good thing. I love the patient come and say, I'm coughing only when I'm doing hypertonic. Right? That's the purpose, that's a good thing. But you have to tell the family or they get worried about it. And then after that, you do the mucolytic, whether it's palmazine or whether it's N-acetylcysteine. Palmazine, actually, there is a product in the Russian product that is generic, that is very equivalent to palmazine and a lot cheaper. So also we mentioned that to the Ministry of Health, and he said he'll work on it. So I will connect him with the Russian counterpart to see if they can get that. And then if they have Pseudomonas, we do Toby. You can do amikacin here, it's fine. Or amikacin or garamycin. And then we have colistin here, right?
Yeah.
Right. I don't use colistin that much, but we can use it, that's fine. I mean, I don't use it because I have other alternatives, so we can use that. And casein is another one, there's astrianum. Again, it's not here, it's fine. You do what you have. And then you're reducing the swelling and the inflammation by inhaled steroids. We do not give inhaled steroids unless there is an asthma component to it. So when you do the pulmonary function and if there is a hyperactivity of the airway, or if you're hearing wheezing, there is a strong family history of asthma, then we give inhaled steroids. But we don't give it to everyone.
What is the order of inhaled steroids?
This is the order. So you're opening by bronchodilator, and then if you're only doing bronchodilator, then you're doing airway clearance following that. But if you don't, then you open the airways, you hydrate the airways with a hypertonic. You do the mucolytic, so the N-acetylcysteine. Then if there is bacteria, do not give amikacin or garamycin if you don't have Pseudomonas. So I was told by somebody that, oh, everybody has Pseudomonas, so I'm just giving it to every patient. You can't do that. So you really have it if there is an infection.
We shouldn't mix the antibiotic with the steroid. During the inhalation therapy, or we can
What, can you say that again?
antibiotic with corticosteroid inhaled therapy. Can we mix in the same session?
Yeah. One after the other. So I have a lot of
And you have one session that includes both the steroid plus the dexamycin.
in the cup.
Yes.
Well, the steroids are inhaler. You're talking about using
The inhaled antibiotics
Direct.
and inhaled steroids.
Yeah, I mean, the inhaled steroids come in an MDI, so that you can. Okay. We don't usually mix it, right? I mean, we don't mix it. And we usually, most of the time, use the inhaler rather than the glyceride, unless it's a baby. Even babies, we use the air chamber with them with the mask, so we don't need to mix it with anything. And also, you have to be careful with the time that you're asking the patients to do things. So if you can do inhaler rather than nebulizer, that saves them some time. So we keep track of that as well. Yeah.
Usually we do open the airway and we give a hypertonic saline. We usually consider it as a mucolytic.
Oh, the hypertonic?
We don't give a mucolytic after. Should we give mucolytic?
Yeah. And I know it's cheap here. I know it's not expensive. Yeah, that's what we usually like to do, because the hypertonic is not a mucolytic. It's just hydrate the airways and then cause it cough so they yeah. Right, that's what we usually do.
So you give, like, this is a sequence of 5 nebulizer treatments that the patient has to do twice a day?
Yes. Well, the palmazine is once a day, or the N-acetylcysteine is once a day, that's fine. And I like them to do that in the morning so they can open up the airways, and then you do the airway clearance after that.
Okay, because like Dr. Mona said, we normally just use the hypertonic as a mucolytic, and we don't add another one.
Right, but it's not a mucolytic. And again, you can look at your protocol adjusted. And again, that would be a QI project of like how to switch the treatment plan to make it more, streamlined with others.
Yeah.
Right.
Because I don't think our patients will comply with this number of nebulization.
Well, not every patient will need all of these
Yeah.
things every time, all the time. And also that's why we use the inhaler for the inhaled steroid, because it's very quick and so it's not a nebulized treatment that way.
And
Not everybody's gonna be on antibiotics or
Yeah.
steroids, right?
But also, since your patients are not used to that, you can start by having everything once a day. And then if the patients are moderate severe, then you can tell them, okay, I want you to increase it. Because also here in Egypt is funny because my kid is doing well, I'm not giving them, I'm giving them a break from the treatment. So they need a lot of education about, no, you need to do it every day. So some of my patients, if their lung function is good, and if they're, especially teenagers, I do it once a day if the lung function is good, meaning 100%.
If we do this once a day, can we split it into two parts? Like one part in the morning and the other part they do at night? Like
Right.
instead of doing 3 or 4 nebulizations in the morning,
Sure.
maybe 1 or 2 in the morning, 1 or 2 at night, of the different, like split them.
You can do that.
1 into 2 or 2 and 1.
I would suggest doing a bronchodilator and a mucolytic or a hypertonic once, and then a bronchodilator still the second time with whatever else you're doing, right? With your antibiotic or you could do hypertonic in the morning and acetylcysteine in the evening. You can break it up in those ways.
Right, that would be fine too. And that's why I usually use a lot of inhaler if I can. So a literal inhaler is fine, steroid inhaler if they need. Not everybody gonna be in steroid. Don't put everyone in inhaled steroid unless you think there's an asthma component to it.
Did you find
Right.
Did you find any difference between the ones that you used, just the inhalers, from the ones using the nebulized forms? So there was no change?
No. And actually the inhaler is more convenient.
Yes, of course.
CF kids like the nebulizer because it's moist coming in. So a lot of the time, there is a strianum which is very short, takes 5 minutes to inhale, versus the Toby which takes 20 minutes and it's twice a day. And the patient loves even though it's longer, but they love the sensation of the nebulization. So I offer the inhaler albuterol all the time, and some of them say, no, I like the nebulizer.
It's becoming more popular with our patients to use the mesh nebulizer. Like the mesh nebulizers, they're the small portable ones. Are they compatible with this?
That's very important, and Sharon can help you with that. The problem with the mesh nebulizer is that we don't know the particle size, so that's really a problem. And also, if you're going to overuse it, it's going to break quickly.
Yeah.
So that's why we don't usually recommend it. Sharon, you want to add any?
Yeah, I think you just have to be aware of what the particle size is for deposition on that, and if that's a approved medication to be given that way.
Actually, the AstraZeneca website, they have a program that sells nebulizers to patients, and it includes sometimes the mesh nebulizer. So I'm sure that it's compatible with the budesonide nebulized budesonide because they are actually selling it on their site for patients.
Hypertonic saline, palmazine, those things are often the ones that are questionable whether they're compatible. So those are the ones that you need to look into.
They
Yeah,
tend to clog up.
hypertonic might
Yeah.
the mesh. So we usually don't ask it because it's very salt concentrated. Palmazine might be okay, but the hypertonic you have to be careful because it will destroy the nebulizer quickly.
That, and then the other question is how easy are they to clean, to maintain infection prevention? What are their requirements? They may have a little bit different than the traditional cleaning methods that are recommended.
Right. So if you have the regular nebulizer, it probably lasts longer than the mesh one, so it's not wasting a lot of money for the patient.
It's just that it's a little noisy and patients sometimes
Well, they can try. They can try with any stuff, sustain with antibiotics. But I would check on the particle size. If you don't want it too small, you don't want it too big. Any other questions? So, other medication we give the enzymes, usually through the mouth. We don't give it, I mean, I don't know if you have a lot of patients with G-tubes here. But for us, we do, and we usually don't put we don't open the capsule and put it through the G-tube because it can plug it, so we don't do that. So we focus on high calorie diet. I mean, when I come to Egypt, I usually gain a lot of weight, but these patients are not gaining the weight. And why aren't they gaining the weight? Because they're sick and they're consuming a lot of calories. I do a lot of appetite stimulants, and I know you have T-reactine here. So I use it in the US all the time. In the US, it's T-reactine. So, and it's been very, very helpful to improve the weight. Very important to aim for your BMI to be at 50%. When you're at 50% or higher, I usually aim between 50 to 70. So when they get sick, they don't drop below 50. And that would actually help the lung function be in good shape as well. We have supplements, and I know you have supplements here that you can give to the patients. And like I said, the appetite stimulants are really, really important part of it. And we have several of them. There is an article that I wrote several years ago. I can send to you about the appetite stimulant choices. But the easiest one is the T-reactine, which is, you know, an old antihistamine that's, I think, very safe to use. Then you have to do the CF vitamins. And this company that I don't know if you guys talk to them or not, but it's a combination of all the A, E, D, and K. So it's really important to give, because if you give them individual vitamins, it's a lot. So which a lot of the time do. We do antihistamine if they have allergy symptoms. So if they have any runny nose, congestion, we usually give them antihistamine. And then we do a lot of nasal steroids, like the Flonase or whatever we call it here. Because a lot of the time they have nasal polyps, and then the nasal spray can reduce the size of the polyps. So when I explain to them, they usually can use it. And then a lot of them have constipation. So we do a lot of like stool softeners and laxatives. We do a lot of Merilax. I don't know if you have that. I think you have it in a different name here. Or prune juice, so whatever you have. We use acid reducer medication that will help with the enzyme work better. And then, if they have asthma, you give the asthma inhaler. If it's diabetes or liver disease, according to what you have. Any questions? All right. So new colonization, which is really, again, really important that you work with a good lab that can tell you if they have colonization. We mainly treat the Pseudomonas. With any Pseudomonas, there are several species of Pseudomonas. Any Pseudomonas I treat if they have it. So here you can start with the garamycin twice a day for 28 days. And that's kind of similar to what we use with the Toby. And we usually start with 28 days, and then we culture them again when they come every 3 months. So when they come back, we culture them. If they have it again, then they're chronically colonized. So we do 28 day on, 28 day off regularly till they're culture free, they're Pseudomonas free for 2 years. So that's what we are using. The Zithromax, I think you have it here. And I don't use it as much in the US because I have Trikafta and the kids are doing much better. But you can use it here. I think a lot of kids in Nanshan are using it. So if the patients are less than 40 kilos, you give them 250 milligrams three times a week. If they are 40 and above, you give 500 3 times a week regularly. That's an anti-inflammatory, not an anti-infective dosing. It doesn't matter what the weight of the patient is, even if they're 5 kilos, 253 times a week. And if the N-acetylcysteine or hypertonic have not started, we start it if they're colonized. If the colonization starts, I immediately start the pulmodiol with the N-acetylcysteine and the hypertonic. Because now they're getting to the next level of CF. And if the culture if the symptoms are bad, like they have symptoms, they are not gaining weight well, I might admit them for IV antibiotics. So if they are doing well, but they colonize, then I treat as an outpatient with the vancomycin. If they have symptoms or they're not gaining weight, or I think there might be like, they're not doing as well as I think they should, then I admit them for IV antibiotics. The IV antibiotics are combination. We do aminoglycoside and cephalosporin. There is, and I know you don't do levels here for the tobramycin, for the aminoglycoside, which is a problem because it can have liver, you can have kidney damage, you can have deafness. So there is a study going on in the US that seeing, are we really needing 2 antibiotics when you have Pseudomonas, or 1 is enough, cephalosporin. So that would be great because Turkey also, they do not check levels. So which I have no idea how you can do that because you might end up with renal failure, which we had sometimes. Any questions?
Yes, please.
I'm asking if the patient is in the early stages, is not colonized, is not symptomatizing, he has no respiratory affection, should we start as a prophylactic inhaled antibiotic, chest physiotherapy, or we should wait?
No, don't use prophylactic antibiotics because you're creating resistance.
Okay.
So I would never use tobramycin or gentamicin unless we have Pseudomonas.
What about physiotherapy or chest care?
That's I teach them that you have CF diagnosis. I'm starting albuterol, and you're doing the
Even if it is not symptomatizing.
Yes. And I usually tell them, don't expect babies to cough up something when you do airway clearance, because what happened, the mucus will come out of the lungs and the baby will swallow it and come out of that's fine, come out with the stool. So you have to tell them that, because otherwise they tell you, I don't see anything, why am I doing it? So very important to, airway clearance, and then also you're teaching the patients that this is the way of life. You're going to have airway clearance every day. So, and like I said, if airway clearance by hand is hard, do the acapella, which I don't think is, or aerobic, I don't know which.
Yeah, we have aerobic.
Actually, the company is going to be represented tomorrow, and we have a short talk on aerobic.
Perfect.
But we don't have acapella.
That's fine. I mean, actually the patient likes aerobic more anyway. And I usually give it to them when they're traveling or something like that. So, so you can work with them. Of course, they have to be big enough or old enough to be able to use the aerobic.
Question. When you use just one antibiotic, did you find any difference in the results between people taking only one antibiotic or 2?
The study is still ongoing.
Okay.
So it's really hard to recruit for that study because the patient has been doing so well.
Yeah.
So the study started 2 years ago, and I had no patients included, not a single patient, till like just 2 months ago.
Okay.
Because I had people are coming and they don't have Pseudomonas because they've been healthier. But so once the study is done, you'll immediately know the results.
Also, we usually, because we don't measure the levels, but we go for kidney functions every 5 days, and we discontinue after we repeatedly do that. But will this also pick it up, or is, because it is dose dependent, we never know when will it happen. So I guess it's worth it to try it.
Yeah, so our protocol is that if they are aminoglycosides, we do the BUN, creatinine, like the kidney function. Is it once or twice a year? A week?
Usually it's every 5 to 7 days,
Yeah.
depending on what the level has been beforehand, right?
Yeah. So we usually do the levels and the kidney function.
Okay.
But since you don't have levels, we go for kidney function. Yeah. And also you have to screen the patients. Are they feeling dizzy? Because sometimes they have vestibular dysfunction rather than hearing deficit. So you have to ask them, and then your physical therapy should help if they have vestibular dysfunction, which we can go over in the next few days.
Another quick question. previous slide actually. No, it's like I just want to know what's the role of the antacids on the pancreatic enzymes. What does it do?
Right. So we don't use it automatically. We usually start with the pancreatic enzymes, and then they have any reflux symptoms. We started. But sometimes we add it if you're already at max dose of the enzymes, and then they are still not where they should be, then we might add that.
Oh, I mean, so we do add it just to reduce the acidity, but it does not like augment the effect of the pancreatic enzymes, or does it have
Basically, it starts them working sooner because they're enteric coated. So if you're in an acid environment, they won't start working. And so if you reduce the acid environment, they can start working a little bit sooner.
Okay,
And
so it's just to push or to augment the effect of the pancreatic enzymes,
Yeah.
so not to make
Correct.
okay.
Yeah.
That's the point I just wanted
And
to
I think people overuse.
Yes, of course.
So that's why I actually tell them, scale it down, because they are overusing that, yes.
Going back to the gentamicin, we do the kidney functions on inhaled gentamicin every week?
No,
Okay, because we don't do that.
we don't do that.
We do the glucose systemic gentamicin.
yes.
Yeah, there are some studies looking at if inhaled also causing kidney damage. I've used inhaled tubermicin for years, and I haven't. Maybe I've seen one or two patients that have issues with it, but I usually don't. It's mainly the IV form. Okay. These are all very good questions.
The ototoxicity,
Yeah.
how to monitor that?
Well, if you don't have levels, so you didn't really know, so maybe once a year send them to E.U.P to do hearing tests. That would be very helpful. We've been doing that, and also we do vestibular testing because it's underreported. And we've done a study in my center where we looked at all these patients and we did vestibular testing on them, and there's quite a bit of them that have issues, that they're feeling dizzy, but they're not telling you the right symptoms. One of them kept telling me, well, I feel tired. Well, I don't know what to make of that, right? Or, I'm just not, it's mainly, they're not going to come to you and say, well, I feel dizzy and I'm going to fall down kind of thing. So vestibular testing would be a really good one to do as well, but at least hearing test once a year.
There is a screening for that a lot of people do that we can probably get and share, where they do some very basic things to screen, and then only go on to full testing if it looks like they need it.
And that's for the inhaled.
No, it's all with
I think it's really
Okay.
any exposure over time. So if you're on the inhaled long term, every other month, then they'll say, just screening. It's a lot of questions as opposed to testing.
And that started. We didn't really do that for the nebulized antibiotics.
And
We
just
started doing
recently
it.
we started.
And actually, Chris will go over that, the vestibular testing. Yeah.
It's a lot of
The team here is good. All right. So again, do not treat with garamycin or amikacin unless you have symptoms. I rounded with them in the inpatient. So it's lovely here. You ask the patients, can I take a picture with your kid, or can I take a picture with your kid? They're like, yeah, take it. They're very generous. So the antibiotics again and criteria for admission. When do you admit patients? So we start if they have an increased cough, sputum production, decreased appetite, weight loss. We usually do antibiotics orally first, because I'm not going to admit anyone that. I'm usually if it's too simple, like I'm coughing and having sputum production. We usually tell them increase your albuterol and airway clearance to 4 times a day and call me in a couple of days. If it's still going, then we usually start the oral antibiotics according to the culture results. For admission, we usually use 1 antibiotic, but if it's Pseudomonas, we use 2. We usually treat for 2 weeks. We do send them home with declines or the longer antibiotic IV line, and we do it either at home or in the hospital. Here we probably do it in the hospital, 2 weeks. If there is any pneumonia in the X-ray, you pay more attention. Pneumothorax, depending on the size of the pneumothorax, you have to have good surgical department to work with. So the pneumothorax, hemoptysis. If patients have meconium ileus, our surgeons, they would alert us right away, because that's CF still proven otherwise. So it's really important to work with your surgical colleagues, because they can help quite a bit. So again, if they have increased cough, like if the antibiotics orally that you use is not enough in 2-3 days, we admit them for IV. So that means the oral antibiotics failed. So we just admit them for IV antibiotics. Or if they have pneumonia or hemoptysis or pneumothorax, I'm not messing with that. They're in the hospital. You just tell them you have shoulder pain, you come for X-ray, you're coughing up blood, then you come into the ER, and then we work with you on that. These are the airway clearance ones that we use. So this one is, instead of hand percussion, they use this cup thingy, and they're both equivalent really. And then we have the aerobica here, which a lot of the patients like aerobica more than acapella. So we give them a lot of it. And then the vest is really, we give it because they can combine your nebulizer with while you're doing the vest. To improve adherence with that. And again, you don't have to have the vest. If you have it, it's an bonus. So, types of airway clearance, like I mentioned. So you have the airway clearance by manual, oscillometry positive pressure, external pressure, high frequency chest, wall oscillation, autogenic drainage, and coughing and huffing technique, which Chris will go over all of that. He does it over and over, and he will also, in Ancients, he did it with the families to show them how to do it by hand. These are little kids. This one was so cute. She was like crying her head off the whole time. Chris was trying to tape session of airway clearance, and then everybody said she's not going to let him touch. She's not going to let him touch her. He took her, and she just like, oh, she liked it. So he did airway clearance on her, and she was like happy as can be. So it was very, very cute. And then you can see she was in the hospital with IV. This guy tried the best, and we needed pictures because when somebody donates to us to bring here, they want to see that the patients are getting it. So very important to make them happy because they keep donating. So that's like we did with the spirometer yesterday. So this one was mainly, can we take a picture of you? And he was like, yes, excited. So for here, you can do the speed of culture every 3, but you can do it every 6 months, as long as it's a good lab that can give you good results. We also do it with exacerbation. Well, if they come to clinic and I'm doing it in clinic, we're not repeating it. Fecal elastase, we do it for pancreatic sufficient patients. And for the newborn screen, we usually do it. If they are insufficient, I don't do it again. Sufficient, we repeat it every year because they can convert to insufficient at any time. We do vitamin D level. I know you don't do it here, but we do it there. Pulmonary function, we do it perfection. You do it here? Oh, okay. We aim for 30, the level to be 30 and above. So if it's less than 30, we give them supplements. And indeed, in Egypt, I mean, the sun is out every day. Just toss the kids out in the sun and get them. I'm amazed, really.
I think it's just our vitamin D level. I don't think we're insufficient. I just think that we just have it.
Well, somebody told me that. You're special. I know you do more bronchoscopies here than I do in the US for my CF patients. So the excuse they told me in Ancient is that, well, the culture is not accurate enough. So I told them to do it as a QI project, but they never did, which you compare, or a research project, depending on how you design it, comparing results of, just swabs versus sputum versus bowel, and then see what results you're getting. And I think somebody did it, and they said bronchoscopy, we get a lot more bacteria than we do from the throat culture or the sputum culture, which I think that's a problem with the lab then.
Actually, I'm doing this research now, but not on the CF patient, on the infection, infection. We do current throat swab or sputum and see the difference.
Right. I think that they see that as well there. So I mean, if you're suspecting that the patient might have, like doing badly, suspecting that they have bacteria that you're not recovering, yes, you can do the bronchoscopy. We do also high-risk CT. So in Egypt, radiology, you can do chest X-ray yearly. I know that you do also high-risk CT more than I do, so it's fine. You can do that to evaluate. Abdominal ultrasound is really if indicated. I don't do it unless I have a problem. And then the echo, we stopped doing it years ago. But here you're having pulmonary hypertension, from the right side of heart failure, a lot more than I see. So yes, you can do the echo to make sure that you're not getting in trouble. And then the labs usually is once a year. And this is the list of the labs that we usually do. So when I saw this kid here, I was very excited because he was 14-year-old, and I haven't seen marijuana at the time. He was the oldest one. I've seen him, he's speculative sufficient, and so I had to take his picture. I think that's one of your patients, Miriam? Yeah, I think it's Miriam, right? And then this guy is from the Azib, which he actually had the G-tube when he was a baby, and he was really in bad shape, and gradually got much better and got the G-tube out. The registry that I've been lobbying for heavily is I created a registry that's very simple to use and shared it with everyone. But I know that you guys have your own registry, and then Ain Shams have their 2 or 3 different registry. They entered part of it into that registry, but some of them I got extra. So when I'm writing the paper now about the mutation and the presentation of CF in Egypt, I talked with everyone and give me all your data so that way I can include you in the paper. So the latest one that will join that effort hopefully is Dr. Mona Al-Falaki, which she's been always excluded as she requested, but now she said no, she didn't request that, but fine, we'll take her. CF in Africa, there is a group now that's CF in Africa in all the countries. So a lot of the countries have 1 or 2 patients. Like Ethiopia, they have a sweat test that we gave them from MIFA, and they diagnosed like 6 of them died because they have nothing. They don't have albuterol, they don't have antibiotics, they don't have nutritional supplements, so you're practically diagnosing them and letting them pass. So I'm part of this. Red Cap thing, and I don't know. Maggie was telling me that's not going to happen here. But what can happen is a national registry, and then that national registry can be shared with the African. It's not patient identified; it's a de-identified patient, but at least to know what's happening with the patient. Very simple, and I can show you if you're interested. But for now, if every university have their registry, then that would be good to work with. The problem is the patients go from one hospital to the other. So I don't know who are your patients versus who are the ancient patients. So patients keep moving around so they can be registering for different, different institutions. So the questionnaire is mainly date of birth and age. Does IRB in your country allow for collect exact date of birth or not? Or is it better to use only, like these are questions that was the registry, the African group are asking for. So all of these, again, I'm just presenting it because it's a new thing, and see if we can work on that. There's this list of the therapies. We can add more because they always have other to add whatever you would want to add. And then also what bacteria they have. Smoking education level, which we have in our registry that we created here, but shorter version of it. This is actually, so it's funny, I wanted a family advisory board because at that time, like 3 or 4 years ago, I wasn't going anywhere with the Ministry of Health. I couldn't get a hold of anyone. And I said the only way to do it is to get the family together and have a family advisory board. So we did, and this is their logo. And it's because of the bureaucracy in Egypt, it's everywhere. They are doing it as part of the chest group. I mean, there is an organization here, the pediatric thoracic group or whatever. So that's part of it. So that way they are not a standalone organization, so that we need a lot of paperwork. So in summary, it is good that we have CF, and we know that CF exists in Egypt. Now, what to do about it? Second, we need the diagnostic tools. So having the 4 equipments in 4 centers that I mentioned is great, but now we have another problem. The kits are expired, it's finished, we need more kits. So it would really be very important, so I'm going to be hooking up with Dr. Naveen. I'm not going to leave her alone. I know your mother. Because if she knows somebody that can connect with a Turkish company, which is wonderful, I'm just looking to see if Asa's here. Because really you need stable supply of kits and you need stable equipment. So if your equipment is 20 years old or 25 years old, you really need a new one. I think it's about time. The Ministry of Health are willing to work with you guys. I actually sent him all the information about the company. He said he can help. But if we have a distributor here, that will be the way to go. Having a distributor so they can service, they can do things and the company in Turkey doesn't really know anybody in Egypt. So they keep asking me, and I'm like, okay, I don't live here, so I don't know anybody. But if Dr. Naveen knows, I'm working with her. and as you can see, like, we have meetings like this, and then things come up in the meeting. Like, when I was sitting next to Dr. Abuna Al-Gandria, and she said, oh yeah, I know the Minister of Health, he's my relative. I'm like, okay, I'm holding it to you. You're not leaving me right now. And that's how we're making progress in Egypt. Educating everybody is really important, and it's working well. I think that the collaboration and working with me and my team is really very helpful. And we're very thankful for that, actually. Providing the necessary medication, as you increase awareness, like what happened with Creon. Creon was, we all used to get that in bags coming into the US to here to give to patients. And then, the drug company realized that there is demand, then they start working and having it available in the country. So that's really how things work anywhere. And then training the medical team, especially about proper nutrition and physical therapy. Very important. It makes a huge difference. And that can be in itself like a lot of quality improvement, at least a couple of them. And finally, teaching about quality improvement again. This is an article written by Jonathan Gu from the UK. He presented it everywhere, and it was published in Lancet. So he really did a very good job in the journal of CF. He called me and he said, do you think there's CF in Egypt? I'm like, yeah. How many? So I contacted you guys, and I was told 800 at the time of the publication. And then then he asked, how many do you expect? So I told him about 4,000, 5,000, 6,000, we don't know. But it's in the thousands that we need to test more and have the data available. So that's really important. It's funny that also India, here, they only have 600 identified. But then when they looked at that data and they said, oh, we should have 36,000. India is a mess because there are different religions, different governments, different this and different that. So I have a colleague that's working with India and it's a nightmare. But in Egypt, I'm very excited because we all work together. So really the goal is to diagnose everyone with CF and then provide treatment for them. China, they always said we don't have CF in China, but I have Chinese Americans that have CF in the US. So now they started to test very slowly. I was in Philippines, I think it is Philippines or Indonesia, I don't remember now. Recently, and a doctor came from Vietnam and he said, we have CF patients, we have 3 CF patients. I'm like, write it up. So he did. So I'm going there in September, so I'm going to be catching up with the guy. But again, you know, the way to go is that we need to publish as much as possible from every country so people are aware, especially low middle income countries. So people are aware that CF exists there and that we need to provide Trikafta or the other, or Korea. Like I said, Tunisia have Trikafta now, but they don't have enzymes. So it's a very interesting experience. A lot of the African countries, they have CF, but they don't have the treatment. So it's all increased awareness. And this is our team. I think that's not everybody, but almost. And it's everybody. Kerry is our division director. He is wonderful. He actually was my fellow, and now he's my boss, so I love him. And the idea is all of them are very excited that we come here and we work with you. Very supportive. All the, like, you know, when Sharon say, I'm going to be working in Egypt, thank you. Her bosses are fine with that. When Chris say, I'm coming to Egypt, so no one gave us pushback on people coming in. So everybody in the university are very supportive, which is very exciting. This is the median survival in the US, and you can see we started when it was identified in 38. People were dying before a year of age. As awareness of the disease increased, then the improvement started. The CF Foundation was started right here by a bunch of family members, and they've been increasing awareness. You can see gradually getting better. In the 90s, the CF mutation, the Delta F5 was identified in the gene in 1989, and since then, it's getting better. So we have the Pulmozyme, that was the first medication that was approved for CF. And then Toby came, the first medication approved for CF. So, and then they use it for other diseases, but it came to us as Trianum. And then you have the modulators and Trikafta, and now straight line up. And that's what I want to see in the US, in Egypt here. I want everybody that qualifies for the drug to get the drug. I don't care where they are. I have, like they are saying, well, I have a 30-year-old, can they qualify? I'm like, there is no limit. I give it to 70-year-olds, so, but not me, because I don't take care of adults. But yeah, there's no limit of how old you should be. We lower the age to 5, so 5 and above. Anybody that qualifies should get Trikafta. This is what I'm seeing there in the US. So very important. And that's it. Thank you. Yeah, because sometimes you start, so the question is, would you do fecal elastase for all sufficient patients yearly? Yeah, because sometimes it's just starting and you just really want to know. So we usually start. So it could be like, I'm very insufficient now and I'm showing it by not gaining enough weight, by not doing as well in nutrition as I should. So yes, we do it here. So, and it's with insurance now, right? Insurance paid for it. I'm aware of that.
بس the paperwork is held.
if the insurance is supporting the paperwork, they have actually it's a lot of time.
And also, I think the registration with the Ministry of Health is hard.
Yes.
So, and a lot of the patients, they keep telling me, oh, they are registering with the Ministry of Health. I'm like, how many months that would take? But
Actually, we tried me and Maggie tried to do this and we face a lot of problems.
The registering,
Yeah.
no, the electrical elastic. I mean, if there is a problem, please talk to Iman because she might help.
Yeah.
Because she has a connection now. And maybe gradually we need more people to be working with her because she cannot be by herself. Right?
Samya, correct me if I'm wrong. So like even if you have a degree of pancreatic insufficiency, you may not be symptomatic because it's like about how much fat content you're ingesting and protein. So like even if they don't have steatorrhea, they could still be pancreatic insufficient. So I think it's very important to test even if they don't have symptoms, right?
Yeah, that's what I was saying, is that if the only sign you have is that they're not losing enough weight, then do it. I mean, if they have steatorrhea, if they have all of that stuff, you're pancreatic insufficient probably, but but it's just, doing it. If they are insufficient,
And being on enzymes does not impact the fecal elastase test.
it does.
So you don't need to stop it.
Yeah. Okay. Any other questions? So we all are experts now in how to speak CF.
لا احنا عايزين نقعد مع حضرتك ونعمل a one pager that we can have available for whoever is مثلا في العيادة أو كده.
That would be great, and then I can share that with other universities, so it's easier
We
for
just need
everyone.
like to have a one page thing, just to point out, and then maybe reference a document or حاجة at the end of this page for details that people can visit and look at.
Whatever you need, I'll do it. You just tell me.
Thank you, Dr. Asma. It's so like energizing when you talk about CF. I mean, your passion comes through and it's really energizing. Thank you. نحب نشكر دكتورة سامية في أي أسئلة. Thank you.
دكتورة سامية وهي بتقول معلش أنا جيت متأخر علشان بس كان عندي اوبليجيشن إن العيان السيستيك فايبروزس المفروض إن أنت بتعملي له annual فولو اب ايكو. فيعني حضرتك من الحاجات الورك اب ان لازم يتعمل ايكو كل سنه. فهل ده عشان بس مجرد البلمونري هايبرتنشن ولا يعني هل بتلاقوا فعلا في significant بروجريشن للبلمونري هايبرتنشن في الاطفال دول ولا بس اللي هم untreated والطبيعي ان انت تلاقي طالما هو ويل كنترول بنلاقي البلمونري ارتري بريشر بتاعهم within normal or mildly elevated.
So I don't do echoes much with my CF patients because they're doing well. If you have a patient with severe lung disease or needing oxygen, and I think you see that in here, or that I see in my country, then yes, you do it. So we don't do it for patients unless they're worried about the severe disease, and you can see that there's some sign that you know.
Also very important supplemental oxygen is very important to prevent pulmonary progression of pulmonary hypertension. يعني even في حالات كتيرة جدا احنا من الكرونيك chest disease بنديهم اوكسجينيتورز علشان نمنع الديفلوبمنت اوف pulmonary hypertension والبروجريشن لان الاكسجين يعتبر ثيرابي وبيمنع الفاسو كونستريكشن اوف pulmonary blood vessels. فطبعا احنا بنشوف حالات كتير احنا عاملين عياده سبيشاليزد للبلمونري هايبرتنشن في منهم ناس كتير قوي بيجوا من عندكم كرونيك شيست ديزيز بنحاول ان دول طبعا مع الكنترول بتاع الشيست انفكشن ونديهم سبلمنتال اوكسجين ياخدوه اتليست بالليل وهم نايمين. الاطفال دول بيتحسن جدا البلمونري ارتري بريشر بتاعهم. فبصراحه انا هنا
بتبقى في الهايبوكسيا
في الهايبوكسيا هي اللي بتعمل الفاسو. انما الحالات اللي هي بتبقى كنترول ده غالبا البلمونري ارتري بريشر بتاعها بيبقى مور اور ليس ماشي كويس.
بالنسبة للهايبوكسيا هل حضرتك مثلا في قياسات معينة للأكسجين أو مثلا أكسجين مونيتورينج أو سليب ستادي أو أي حاجة من الحاجات دي عشان نعرف إيه الليفل اللي إحنا لازم ندخل فيه أكسجين قبل ما نديفلوب
والله بصي اي هايبوكسيا للبال 92% بتعتبر يعني ستيمولس جامد جدا للبلمونري فاسو كونستريكشن. فدايما تجيب الاكسجين ساتوريشن اباف 92. فلو عيان عندك less than this better ان هو اتليست في اثناء الاكسسربيشن او اثناء السليب ينام على اكسجين. ده بيحسن الدنيا.
والتارجت ساتوريشن
more than 90 الساتوريشن.
يعني مثلا ما يبقاش يعني 92 up to what؟ يعني هل احنا محتاجينه 100%؟
لا
ولا كفايه
لا
هو بس
لا دول كرونيك
يعدي
92 to 94 enough.
يعني that's a target to oxygen.
So that should be part of the guidelines.
Yeah.
I didn't include it because I don't have many. I don't remember sending anybody for ECHO in the last 10 years. But you have here, so I think if somebody is needing to have oxygen, because that would be a good indication to do an echo. You know, if you have somebody that is severe lung disease, it's a good indication to have the echo. Because you want to know early so that way you can prevent progression.
هو كمان يمكن الكيسز اللي بنشوفها اكتر متحوله من الشست من عندكم هي حالات الانترستيشيال لانج ديزيز. انما بصراحه احنا ما شفناش سيستم فايبروز. هل دي علشان نوت دايجنوزد هير ولا هل هم بيبقوا كنترولد وما عندهمش؟
البيشنتس عندهم مشاكل كتيره جدا. And sometimes this part drops منهم لان هم they have so many things to deal with اصلا. And maybe sometimes patients do not يعني بيحصل لهم
لا هو لسه بنقول ان دي في السيستم فعلا بالبرامج.
ايوه طب ما ممكن صح. لا يعني انتوا اكيد بتعملوا بيز لاين ايكو لكل الحالات ما بتلاقوش فيهم بالمونري هايبرتنشن لان الحالات اللي بريزنتد تو اس يوجوالي مودريت تو سيفير بالمونري هايبرتنشن وده بنلاقيه جدا كتير قوي. بس حضرتك كان انا شفت هنا في الدايجنوستيك ورك اب ان في ييرلي فولو اب ايكو. انا
yearly echo if they have hypoxia, if they have
يعني for severe cases.
Not severe cases. And maybe you're not seeing it because it's not in the radar right now. Maybe they are not focusing on that because we're barely like scratching the surface right now.
حتى ايفن حضرتك الحالات اللي فعلا بتديفلوب بالمونري هايبرتنشن مش بس بنديها اكسجين بنديها ميديكيشنز زي السلدنافيل والبوزنتان. يعني في حالات عندنا انترستيشيال ماشيين على كده بس مفيش حالات سيستيك فايبروزس.
You will start seeing it.
انا عندي سؤال.
الايكو and pulmonary hypertension a lot of times احنا مثلا بنبعت الايكو بيجي لنا من غير اصلا ما يكتب لي estimated pulmonary output. How sensitive is it to diagnose pulmonary hypertension and why is it sometimes
very good question دكتورة ماجي. هو actually we diagnose pulmonary hypertension by echo indirectly. هو ان يعني طبعا بيبقى واضح الحالات اللي زي دي بيبقى في رايت سايد دايلاتيشن رايت اتريال ورايت فنتريكولار دايلاتيشن ومعاهم ترايكاسبيد ريجرج. فعن طريق ترايكاسبيد ريجرج الفيلوسيتي في ايكويشنز كده بنطلع بيها البلمونري ارتري بريشر. بس ساعات ما بيبقى في دايلاتيشن ويزود سيجنيفيكانت ريجرج ده ما اقدرش احلف على الاستيميتد بالمونري ارتري بريشر الا عن طريق القسطره. ففي حالات كده لما بتبقى سسبكتد ان في بالمونري هايبرتنشن كلينيكالي وبالايكو بس مش قادره استيميت بدخلها تعمل دايجنوستيك رايت سايدد كات واطلع بالظبط البالمونري ارتري بريشر والريزيستنس.
يعني سهل اننا نعمل كده رايت سايد؟
لا طبعا لا مش كل الحالات لازم الحاله تبقى ستيبل ولازم تبقى انديكيتد. يعني معظم الحالات لو اتشخصت بالايكو واضحه جدا خلاص. انما في حالات بقى البرايمري بالمونري هايبرتنشن ده كاسيتر اذا ماست لان دي انما سكندري غالبا ما بحتاجش وببدا الميديكيشن الا لو ما كانش الامور قادره استمد بالايكو. ولو الايكو كويس الرايت سايد كويس مش كبير وما فيش ترايكاسبيد ريجرج خلاص يبقى موستلي ما عندهاش بالمونري هايبرتنشن.
بس ساعات بنبقى احنا كلينيكالي انا شايفه في بالمونري كوزيشن سامعه الاسنشويتد
والله الحالات اللي زي دي
يرجع لي من غير
الحالات اللي زي دي ممكن بقى حضرتك تحولها لنا يوم الاحد في عياده البلمونري هايبرتنشن بنشوف يعني ممكن نريفيو انذر، ممكن يكون الايكو برضو از نوت يعني ممكن نعيده تاني نشوف برضه بيتعمل لهم ECG وفي كرايتيرياز كتير عشان يدخل قسطره، لان ده نون انفيسيف يعني لازم يبقى انديكيتد ويل انديكيتد.
لان زي ما حضرتك قلتي at that point العيان ممكن يستفاد جدا ان احنا to improve الاكسجينيشن ونمنع السيكولي اللي
وممكن ياخد medication
pulmonary hypertension with exaggeration of his respiratory compromise.
تمام.
العيانين اللي بتنتشر لانج ديزيز بيبقوا ادابتد لو اوكسجين، يعني هم بيبقوا اساسا ممكن يبقى الاكسجين بتاعهم 89 88 and they are not symptomatizing.
هم ادابتد بس هو بيعمل مشاكل.
بس هو هيعمل
مع وبعدين خلي بالك ان البلمونري فاسكو كونستريكشن فيرست بيبقى ريفرسبل وبعد كده بيبقى irreversible ويعمل رايت سايد هارت فيلير
يعني
لا طبعا لا it should be. وبعدين بقول لك ما تعليش
respiratory failure يعني just adding الاكسجينيشن نعلي الساتوريشنز بتاعتهم عن البيس لاين اللي هم متعودين عليه اللي هو اصلا هايبوكسيك. لما بنديلهم اكسجين it accelerates ان هو يخش في respiratory failure بعد كده.
هو ما انا عشان كده بقول لك ما تعليش ل 192 ل 94 واعتقد ده حتى مدالي الليفل المطلوب في حالات الكرونيك اوبستراكتيف لانج ديزيز وكده، انك ما تعليش على كده عشان الكرونيك هايبوكسيميا.
So this is a great collaboration that you can start. So maybe we'll sit together and identify what criteria you wanted to send the patient, and then we can use as a report for us also.
Yeah, I think it's very
يعني ممكن كل حالات الدياجنوز سيستيك فايبروزس عن طريق عياده البلمونري هايبرتنشن يبقى في بيز لاين ايكو عندهم هو فولو اب.
Yeah, and we can start with the ones with the moderate severe lung disease or hypoxia, not the milder ones.
Okay.
So, thank you very much. I'd like to introduce Dr. Amy Zilber. She's going to talk to us about how to